Good afternoon, everybody, and my heartfelt thanks to IMA Purulia, Healthcare Foundation Purulia, and ESB, and especially Dr. Pankaj Singhania for inviting me to this beautiful place. So I start with this hypothetical case. This is a lady 11 weeks into her pregnancy, and she has come with a report showing TSH of 0.1. So of course, the first question that we need to address is whether this is abnormal at all. So brief recapitulation of the physiological changes that occur to the thyroid function during pregnancy. The increased HCG stimulates the TSH receptor, leading to increased T4 formation, increased estrogen leading to increased thyroxine binding globulin and therefore increased T4. And if we look at the temporal changes in the different, so parallel to the rise in HCG and TBG, there is an increase in T4 level across the first trimester. And sort of a balance between the HCG and the TBG, the free T4 also shows a slight rise in the first trimester, after which it falls. And for TSH, just the opposite, there is to occur around week 7. The lower limit falls by around 0.1 and the upper limit by around 0.5. Slide is not changing. So ideally, and then there is a gradual increase, but almost in many cases it's still lower than the non-pregnant reference ranges. Ideally, of course, we should use the population and trimester specific data, in absence of which we can use reference ranges obtained from similar population using similar assay methods. But most of the time, none of these are available, and we end up using the cutoffs that were derived from TPO negative euthyroid women in iodine sufficient areas. Regarding T4, of course, ideally in pregnancy, free T4 would have been the more appropriate marker, but the ideal assay for free T4 is not what we commonly have. The free T4 reports that we get are basically immunoassays, not LC-MS, and they are fallacious. And a better alternative possibly would be to use total T4 immunoassays with appropriate cutoffs. And talking of appropriate cutoffs, the T4, after week 16, it increases around 50% above the pre-pregnancy level. Between week 7 to 16, there is around 5%. What we expect the upper reference range for T4 to be is to be increased by 20%. That is 11 minus 7, so 4 weeks into 5% per week. We do have some reference ranges derived for TSH and T4 from IPJMR. Anybody interested can go through. So coming back to our patient, these were her T4 and free T4 values. And so the possibilities that we now have in our mind, of course, gestational transient thyrotoxicosis due to HCG, Graves' disease, either newly diagnosed or a pre-existing, and rarely autonomous functional nodule or iatrogenic thyrotoxicosis. Now, talking about gestational transient thyrotoxicosis, it's not very rare, and as it is related to HCG, of course, it's more common in multiple pregnancy, those with increased vomiting and hyperemesis gravidarum. Mostly it is self-limiting and resolutes by the end of first trimester, and it can recur in subsequent pregnancies. But Graves' disease, if left untreated, could have grave complications on the mother in the form of miscarriage, preterm delivery, congestive cardiac failure, PIH, etc. And of course also to the fetus in terms of prematurity, IUGR, and multiple different thyroid dysfunction of the fetus. And even in the long term, it has been seen to pose a risk for seizure disorders and neurobehavioral disorders in the child. So as of now, gestational transient thyrotoxicosis have been mostly believed to be a benign condition. This is a recent paper which showed women with GTT could have an increased risk for GDM, which was not seen even in those with treated or untreated Graves' disease. Differentiating gestational transient thyrotoxicosis from Graves' disease is sometimes straightforward if there is pre-existing or new onset overt thyrotoxic manifestations, which are almost always very less severe in gestational transient thyrotoxicosis, except in cases of hyperemesis gravidarum, in which there can be a significant amount of weight loss as well. And goiter and orbitopathy, if they are present, of course, they are indicators of Graves' disease. And some studies have suggested the role of USG Doppler for the inferior thyroid artery systolic velocity in differentiating the two. Gestational thyrotoxicosis management, as we all know, is mostly conservative. No role of anti-thyroid medications. In selected cases, maybe beta blockers, except atenolol. And there have been case reports of thyroid storm precipitated by hyperemesis gravidarum in the absence of Graves' disease. So this is something we need to be careful about. So looking at our patient with high T4 values, obvious orbitopathy and quite some symptoms, the most likely diagnosis, of course, is Graves' disease in pregnancy. Usually TSH of 0.1 is not something which we see in Graves' disease. Usually it is lower. But for the sake of discussion, let's assume she had this thing. So what next? Do we need to do a TSH receptor antibody for her? So if we go by guidelines, in the first trimester, trap testing is indicated for new onset thyrotoxicosis if there is a diagnostic confusion regarding whether it is Graves or not, and we are contemplating anti-thyroid drug therapy. For those who have pre-existing Graves' disease, if they are in remission and not on any anti-thyroid drugs, it is not necessary. If they are still on anti-thyroid drugs, there are multiple reasons why TRAB estimation is necessary. And if they have undergone some form of permanent ablative therapy, be it surgery or radioiodine ablation, the TRAB will persist in the mother for a long time. So again, TRAB testing becomes necessary. So this lady had a TRAB that is quite high. So we need to manage her. So anti-thyroid drugs are the mainstay of therapy of Graves' disease in pregnancy. Radioiodine ablation is absolute contraindication. Surgery, sometimes if they develop severe adverse effects to ATD, and usually it is in second trimester. So when we are giving anti-thyroid drugs in pregnancy, it's almost always a calculated risk because they do have adverse effects on the mother, teratogenic potential, and a number of and the high risk of fetal hypothyroidism as well. So talking about the teratogenic effects, the incidence is not very different between thioanamides and propyl thiouracil, but the severity is of course more in the methimazole carbimazole group due to the thioanamide embryopathy like aplasia cutis. This is a picture of koala latracia or omphalicil. With propyl thiouracil, relatively less severe effects like preauricular sinuses. Some case reports of cardiac outflow anomalies have been there. So it's almost proven beyond doubt that PTU increases and leads to PTU has lesser and less severe teratogenic potential. But this is another important, interesting paper in which they showed that compared to PTU exposure alone or methimazole exposure alone, if a fetus has been exposed to both of them, the teratogenic risk increases several fold. So possibly a preconceptional switch may be better than switching from PTU to carbimazole or carbimazole to PTU during pregnancy. Regarding the maternal risk, obvious concern is hepatotoxicity and fulminant hepatic failure with PTU. Sometimes rarely agranulocytosis with the thioanamides, but there is no role of prospective monitoring. So the general recommendations regarding ATD therapy, Graves' disease should be treated only if required with anti-thyroid drugs in the lowest effective dose. Propyl thiouracil is the preferred drug till at least the 16th week of gestation, following which we can either continue or shift to thioanamides, the dose ratio being 1:10 for methimazole to propyl thiouracil, for carbimazole around 1:20 for methimazole to propyl thiouracil, for carbimazole around 1:10. But the T-half of PTU is considerably shorter, so it requires multiple doses. The dose requirement significantly falls after the second half, and for some women, they may remain euthyroid without any drugs after the 34th weeks. There are some other medical options available for those who are intolerant to either PTU or thioanamides. So our patient, she was started on propylthiouracil 150 milligrams per day, following which now she came at 15 weeks. TSH was still a bit suppressed, so the dose was increased to 200 milligrams per day. So was this a right step to take? So before I discuss that, let's take a look at the risk on fetal thyroid dysfunction of Graves' disease per se and of the mother's T4 does not go into the fetus because of placental D3 deactivation. Around 25 to 50% of it is transferred. However, the antithyroid drugs that we are giving, it gets transferred to the placenta and can lead to fetal hypothyroidism. So a mother with high T4, T3 levels who is also on antithyroid drugs, the fetal thyroid is more sensitive to the antithyroid drugs. And talking about the trap, the TSH receptor antibody, they also get transferred, but they will stimulate the fetal thyroid only after the 12. So if we look at the complications, so inadequate, if we are treating a Graves' disease mother inadequately or under treating her, the trap will cross the placenta and stimulate the fetal TSH receptor, leading to fetal thyroid hypothyroidism. Whereas if we are over treating the mother, if we are making her euthyroid, what are the options we have? So somebody requiring very high dose of antithyroid drugs, obviously advisable to go for definitive therapy like surgery or radioablation. Somebody who is well controlled on low to moderate dose of carbimazole or methimazole, we have several options like switching to PTU before conception, switching to PTU as soon as pregnancy is diagnosed, or we can withdraw with close monitoring. And this withdrawing is for those who have been euthyroid on at least 2 occasions over 1 to 2 months on low dose of methimazole or PTU and declining TRAB level, of course under close supervision, which might be suitable for our patient. Again, this is always a calculated risk. When we are withdrawing ATD, we are basically decreasing the risk to the fetus of malformations due to ATD, but we are increasing the risk to the mother of a relapse of hypothyroidism, especially those who have a higher risk for the same. Talking about the other options like switching to PTU before trying to conceive, again a calculated risk between the fetus. We are reducing the risk of severe birth defects as we are shifting to PTU, but the mother has a risk of hepatotoxicity. So this approach is preferable in younger women whom we can expect to conceive within few months. And talking about switching to PTU after pregnancy is diagnosed, this will be preferred in older women in which we do not know how long we will need to continue the PTU. Talking about radioablation as a definitive therapy, so after radioablation, at least 6 months we need to delay the conception, but the TRAB level can persist as much as a year, so there will be a possibility of fetal hyperthyroidism, and here is there could be the role of block replacement therapy. And those who are having severe or high TRABs or those who are planning conception in recent future, it may be better to go for surgery. So for our patient, we just withdrew the carbimazole because she was on only 5 milligram with relatively good thyroid function with close monitoring. A word about autonomously functioning thyroid nodules. In pregnancy, they are not associated with TRAB production, so there is no risk of fetal or neonatal hyperthyroidism. Rather, the risk of fetal hypothyroidism due to maternal antithyroid drugs must be kept in mind. And so if the requirement is more than 5 to 10 milligrams of methimazole, or if there are signs of fetal hypothyroidism, surgery should be undertaken in the second trimester. So thankfully we have come across a long way from the tacky and remorseful Bollywood dialogues of हम either बच्चे या फिर माँ को बचा सकते हैं. So now the patients have a better choice to make. They should choose a better team of obstetrician and endocrinologists. From yesterday we have received a wonderful hospitality of an obstetrician endocrinologist couple. So thank you so much.
After such a beautiful speech, our program is packed program, so time is very much limited. If anyone have any question, only 3 minutes time. Please, over the mic over there. Ramurthy. Sorry.
Good afternoon, ma'am. Myself Rahul Murthy, parents and PGT. I have a doubt on topic on hypothyroidism. If patient having a TPO positive hypothyroidism pregnant woman, is there any target of TSH first trimester and second, third trimester? TPO positive hypothyroidism.
So it's like more than 4, you have to treat. 2.5 to 4, if it is TPO positive, you should consider treating.
Okay. Thank you, ma'am. Very good presentation, ma'am. Thank you.
Any other question? No.
And I have a question for Sunitra. We often get these patients coming in our first trimester, 10 weeks, 11 weeks. Deepak Chaudhary sir almost sends me one patient every day with a TSH of 0.01 in some cases. Then I do an FT4, which turns out to be normal, and the usual gestational transient thyrotoxicosis. Do we test a TRAB in all these cases? TRAB is not available in government setup mostly. It is a costly investigation. We have to
If you
outsource.
have I would say if you have a strong suspicion for Graves' disease, then you should do if you are planning antithyroid drugs. But usually gestational transient thyrotoxicosis, the TSH is not that low, what we see. So.
And another thing, if these patients, these transient thyrotoxicosis patients, we are sure the FT4 is normal, TSH is low, do we call them back again for test and again and again and again till the pregnancy is over, or maybe the TSH normalizes or never normalizes?
Possibly once I would repeat the TSH.
Thank you.
Now wait a bit. Okay.
Thanks a lot for coming back. Thank you, Sunitra, for that wonderful presentation. And we have shown us a symbol, an iconic symbol of Purulia for all our faculty. Thank you so much. And I would request Dr. Shubhendu Mishra to please come on stage and felicitate our chairpersons. Dr. Deepak Chaudhary, Dr. J.K. Chandro, and Dr. Anita Das wonderfully chaired this session, our first session on thyroid update, pregnancy with low TSH. We quickly move on to our next session. We now come out of pregnancy and the womb and we move to the neonate. To chair this session on neonatal aspects of congenital hypothyroidism, we have 3 chairpersons from Purulia. Dr. A.P. Mandal. Dr. A.P. Mandal is senior pediatrician Purulia, a very close person, very close friend, guide, and maybe always a well-wisher. Dr. Amit Das. Dr. Amit Das is a young budding pediatrician from Purulia. Dr. Amit Das for the session, and Dr. Chinmay Lat, who is almost a younger brother to me, the organizing secretary for this conference. A big round of applause for Dr. Chinmay Lat, who is the organizing secretary for this wonderful conference and helped me with everything. And I would request our chairpersons to please introduce the speaker for the next. And I would maybe take this opportunity to tell something about the next speaker. He happens to be a colleague. We passed the DM endocrinology course together this January from the prestigious IPGMER, and Aditya has taken the pain to come down all the way from Pune today morning for delivering this talk on congenital hypothyroidism. He has done original work in congenital hypothyroidism, and I believe no one will be able to do more justice to this than Aditya Deshpande. Aditya, please.
I would like to welcome Dr. Deshpande. The most important talk that he will be presenting, and it is of interest for all the pediatricians here. Dr. Deshpande, he has done his DF endocrinology and he has done his medicine in the Government Medical College. Now it is up to you, Dr. Deshpande. Please. At the outset, I'd like to thank the organizers for inviting me, and this is a wonderful initiative. Presenting in front of the people who have taught you all about endocrinology is also a dream and also a fear, but I hope we can do justice to this very important topic. So I'll be taking you through case capsules to illustrate the important aspects regarding diagnosis, etiological evaluation, and management of congenital hypothyroidism. So to begin with, we'll deal with the why, when, and how of diagnosis. The first case is a 22-year-old female who. Oh, the slides are not moving. Just a minute. So, as I mentioned earlier, we'll be going through cases to illustrate various aspects of diagnosis, of etiological evaluation, and management of congenital hypothyroidism. So, let's jump into the diagnosis part. We'll try to deal with the why, when, and how of diagnosing congenital hypothyroidism. The first case had recently come to me, a 22-year-old female who was being evaluated for dyspnea on exertion. She had also been evaluated recently for anemia. She had mild intellectual impairment and had achieved menarche at the age of roughly 18 to 19. On examination, she was quite short as compared to her mother as well. And the investigations that had been done so far prior to her presenting to me were a hemogram which showed an HB of 7.2, a 2D echo which showed global hypokinesia with a low ejection fraction, and finally we went around to see her TFT, so her TSH was more than 100, and an ultrasound of the neck showed an absent thyroid gland. So this is nothing but a straightforward case of primary hypothyroidism, since there is intellectual impairment, short height, and because the ultrasound shows an absent thyroid, this is likely to be congenital. Now, what I want to illustrate here is the importance of screening. So, congenital hypothyroidism represents one of the few preventable causes of mental retardation, and it has been established as early as 1960 that universal screening followed by early treatment leads to improved IQ outcomes. But here we are in 2024, where less than 3% of Indian children get screened at birth for thyroid function. And even our institutional data, when we had looked at various aspects of congenital hypothyroidism, we found that children who had come to us from all over the state and beyond, less than 15% of those were screened at birth. And arising out of this need, I'd like to inform you that a pilot project for newborn screening of congenital hypothyroidism is in the works, and hopefully the entire state of West Bengal will be covered with a newborn screening program soon. So as I mentioned before, it has been proved beyond doubt that early diagnosis followed by early treatment leads to improved intellectual outcomes in children. So the question is whom to screen. The answer is simple, every newborn should be screened. It is expected based on Indian data that as many as 1 in every 1,000 newborns is likely to have congenital hypothyroidism. So when to screen is the next question. So a heel prick sample at 40 to 72 hours or a cord blood sample taken at birth are both acceptable screening methods, and these have been established worldwide. And an abnormal screening report should be followed up by a venous sample, preferably within 1 to 2 weeks. So coming to the second case, this is a 1-year-old female, and the heel prick sample done on day 3 of life was normal. Now the complaint is poor height gain and developmental delay, and on examination her length falls below 3rd percentile for her age and her gender, and there is an umbilical hernia present as well. So on repeating her thyroid function test, her TSH was 50. So a TSH that was a TSH screen that was normal at birth, but now the child comes with features of congenital hypothyroidism. We went through the birth records. It turned out that this was a preterm delivery delivered at 32 weeks with a low birth weight, and the child was in NICU for almost 3 weeks. So, what is expected in a normal or in a term child is that the TSH surge will begin soon after delivery and it will peak at around 48 to 72 hours. And that's when we are looking at the thyroid function as well. But in preterm, just a minute. Uh, if you sorry, if you can look at the preterms here, in preterm deliveries, there can be a blunting of the TSH surge leading to a false negative newborn screen. So the point that I want to illustrate here is that preterm delivery can lead to a delayed TSH surge leading to a false negative newborn screen. And this was the case of primary congenital hypothyroidism. And the guidelines, these are pretty straightforward that in preterm children, in children who were sick in and around their delivery, and in those who have Down syndrome, it's prudent to not just screen them at birth, but to repeat the test at 4 weeks of life and maybe even beyond if there is a suspicion. So coming to the third case, this is a 6-month-old male child who had presented with lethargy, constipation. He was delivered at a corporate hospital and on day 0 the cord blood TSH was done, which was 4.2, which is fairly acceptable. And right now the height is quite low. In terms of weight gain also she's doing, the boy is doing poorly and there was no goiter per se. So the TSH at this point of time was 75, free T4 was very low, and on reviewing the birth records, we saw that this was a fairly uneventful delivery. LSCS was done at term, but yet we have a case where the newborn screening has failed us. So the point that I want to illustrate here is, and it has been uh, elucidated in this study as well, that when we are looking at cord blood, the advantage that we get is that we won't miss anyone, because on day 0, if we get the sample and even if the patient is discharged on the same day, the next day, still we'll have a TSH sample. But there is a small but very important risk of false negatives, because in some the TSH search may not begin at the time that the sample is collected. So whenever we are doing a cord blood sample, this is something that we need to keep in mind. So now coming to the how of diagnostic screening, the first point I'd like to illustrate is something is better than nothing. So, but if we have both the options, then heel prick is not just cheaper, it's just 40 rupees per test, including the cost of paper. It's easier to transport also, and the turnaround times are fairly okay. Corporate remains a good option where heel prick is not available, where the patient might get discharged or lost to follow-up quickly. So in these cases, cord blood is a fairly acceptable option. This is a very busy slide, just illustrating the approach to congenital hypothyroidism. Upon screening, if we are looking at a value of TSH that is less than 20, we can safely exclude congenital hypothyroidism. 20 to 40 is a gray zone where we may want to repeat it. And if the value is more than 40, we can initiate therapy. Then coming to the etiology, broadly speaking, it can be classified as permanent and transient. And when we're talking about permanent, primary permanent congenital hypothyroidism, it is mostly that we're talking about dysgenesis, that is a problem in the formation of the gland, or a dyshormonogenesis where there is a formation, there is a problem with the hormone synthesis. Transient hypothyroidism might be because of iodine exposure, maternal autoimmunity, etc. So as I mentioned before, if we take the analogy of a factory, if the factory itself is not well constructed, that is something that can be compared to dysgenesis. Whereas in case of dyshormonogenesis, the gland itself is well formed, but the hormone is not getting produced. So the factory is intact, but the factory is not producing much. So coming to the fourth case, this is an 18-year-old girl complaining of neck swelling, TSH of 22, fairly straightforward. If we can see high up in the neck, there is a lump, and the scintigraphy image also shows uptake in a region which is usually above the location of the thyroid gland. So this is nothing but an ectopic thyroid gland and a case of primary hypothyroidism. Now, what is the implication of an ectopic gland? We'll come to that in the following slides. For imaging, all the Western data or all the Western guidelines advocate a scintigraphy based approach. It is ideal, but in our scenario, scintigraphy is not widely available, and in the absence of screening, many patients are already late to start their therapy. So it is not ideal, or it is not recommended that we hold therapy just so that the scintigraphy can happen. These are the various reports that we can expect on scintigraphy in terms of dysgenesis, dyshormonogenesis. So going back to the third case, that was the cord blood case. In that case, since the patient was already started on levothyroxine, a USG of the neck was done, and that showed an absent gland. That is, there was no thyroid gland present. So, what is the etiological and clinical significance of this simple ultrasound finding? So, ultrasound of the neck, if it tells you that the gland is either absent, small, or just that there is hemiagenesis, that is one lobe is absent, or that it is not in the place that it should be, that is, it is an ectopic gland. All of these represent likely etiologies for permanent congenital hypothyroidism. So, if you get a patient with congenital hypothyroidism where the ultrasound of the neck shows an absent gland, you can be pretty sure that you are looking at something that is going to require lifelong therapy, and the patient's parents can be counseled accordingly. Again, this is an article by my guide, Professor Sujay Ghosh sir, where he had illustrated a USG thyroid based approach based on USG thyroid and thyroglobulin. That is, if you don't get the gland where it's supposed to be, then you look at the thyroglobulin levels. If the thyroglobulin levels are present, then it indicates that there is thyroid tissue somewhere else. So that might point to an ectopic source. So coming to the question of transient versus permanent, because once you diagnose congenital hypothyroidism, the next question that the parents usually ask is, how long will my child require therapy? So if you're looking at levothyroxine therapy that is needed beyond 3 years, we're probably looking at a permanent congenital hypothyroidism. And at diagnosis itself, we have certain clues as to the etiology. So a transient congenital hypothyroidism may be expected if the gland is present on ultrasound, if the dose requirement, even at within the first few months of life, goes down to less than 3 microgram per kg per day, or if there is decrease in dose requirement, or if we have a risk factor in terms of maternal thyroid autoimmunity, etc. So coming to the syndromic associations, here we have a case, an 8-month-old boy had come with failure to thrive, difficulty in feeding. As you can see in this image, there was cleft lip, cleft palate, and in terms of his anthropometry, he was doing quite poorly, and there was no goiter. TSH was more than 100. So this is a syndromic form of primary congenital hypothyroidism, described as Bamford-Lazarus syndrome. We did genetics for this patient, which turned out to be FOXC1 positive, which is expected in this sort of a clinical scenario. Now, this is a quite busy slide. What I want to illustrate here is that once a patient comes to you with congenital hypothyroidism, beyond the thyroid, what you're supposed to look at is that the patient's heart, the patient's kidneys, the patient's hearing, all the other features, they may or may not be present, but these three things can be easily screened, and it's quite cost effective as well. So coming to the management of congenital hypothyroidism, usually we start with a dose of 10 to 15 microgram per kg per day and titrate accordingly. The follow-up, I'll get to that in the next slide. If we have very low T4 values, we might want to start at a value that is closer to 15 than 10. And again, age-wise, levothyroxine doses have been described, but once you start the child on therapy, the titration will be based on the follow-up TFT reports rather than these age-wise descriptions. And the important instructions that you're supposed to give to the parents is that one, if you take this tablet as described, then the IQ and the growth of the child may be normal or may approach normal, and hearing impairment may be anticipated, and the tablets are to be administered in a child. They are supposed to be crushed and to be given either with water or milk at the same time of the day. We cannot expect a child to be in a fasting state when he takes this sort of medication in the interval. So coming to the new burning question that is regarding genetic testing. So here we have a case, a 10-month-old female who is inherited in an autosomal recessive manner. This gene is inherited in an autosomal dominant or this gene is inherited in an autosomal dominant or de novo manner. De novo. Now the take-home message here, even if you just had to take one message from this, that would be to screen all patients and be mindful of false negatives and false positives. Treatment and follow-up has to be chalked out to the patients and to the parents at the first visit itself. Etiological evaluation, even a simple ultrasound may help us, but it is not grounds to delay therapy. We have to start the therapy right away and we can evaluate etiological evaluation. You look at the heart, you look at the kidneys, midline defects. And genetic counseling should be done for all. Genetic testing may be done in selected patients. So, thank you.
Thank you, Dr. Deshpande, for such a compact and nice presentation. Now it's time for the audience to ask any question. Sure.
When you say that
My request, or should I say demands? So, Pankaj insisted that it has to be a case based. So my case is a middle-aged gentleman who presented with a nodule on the right lower half of his neck, and he had a USG report with him that read heterogeneous solid nodule measuring 2.7 centimeter maximum diameter. I did a quick examination and found no voice changes, no hoarseness of voice, no cervical implant value. So how do I approach this particular patient and what are my management options? So you need not focus on the numbers written in this particular slide, but what is important is that a vast majority of those nodules are benign and the risk of malignancy does not depend on the mode of detection of nodule or the number of nodules present in the thyroid gland. Now, as I have said, majority of those nodules are benign, and the list includes benign nodular goiter. Most often you will come across adenomatoid in the FNAC report. At times, chronic Hashimoto's thyroiditis may present with nodule or pseudonodules, to be more specific, adenomas, hemorrhagic cysts, and about 5 to 15% of those nodules are malignant, mostly differentiated thyroid carcinoma, be it papillary thyroid carcinoma or follicular thyroid carcinoma. And on rare occasions, you may come across medullary thyroid carcinoma, anaplastic carcinoma, or thyroid lymphoma. So I am concerned about 4 issues. One, whether I am an ellipsoid shape and lymph node. So this particular gentleman had a hypoechoic.
thanks for the wonderful presentation. Now, session for the
Thank you, Partha, for the wonderful talk on thyroid nodules. I request our chairpersons to please felicitate our speaker for this session, Dr. Partha Pradhan Chakraborty. And for this session, I would request Dr. Rakhi Puria, radiologist Purulia, to please felicitate our chairpersons for this session. Dr. Rakhi Puria has been doing a wonderful job in terms of ultrasonography in Purulia. We have been knowing her for quite some time, and she's a close friend. Dr. Rakhi Puria, to felicitate our chairpersons, Dr. Amrit Khaitan, Dr. Joydeep Kormokar, and Dr. Devashish Biswas. Quickly moving on to the next session. For this next session, I request as chairperson on stage, Dr. Falguni Chakraborty, Associate Professor, Department of Biochemistry, Deven Mahata Government Medical College and Hospital, Purulia. Dr. Gautam De, one of the most beloved juniors, pathologist, RMO clinical tutor, RMO clinical tutor, Department of Pathology, Deven Mahata Government Medical College, Purulia, and Dr. Shobhendu Mishra, a very, very caring senior who is medical officer at the Police Hospital, Purulia. They will take us through this session on laboratory aspects of thyroid function test. And I request our chairpersons to introduce our speaker, who is the person from whom maybe I learned the most in endocrinology of late, Rana sir. Thank you so much.
Good afternoon, everyone, all the dignitaries and the distinguished member of the audiences. I'd like to call upon Dr. Rana Bhattacharya for his speech on common laboratory error in thyroid function test.
Thank you, chairpersons. Thank you, Pankaj, for your nice introduction. Very good afternoon to all of you. So today, although my topic is regarding common laboratory errors, I won't go into detail regarding various bits of laboratory technology. If anyone of you are interested with those, we can discuss later on. I will just discuss few of the highlights, few of the basics of laboratory methods in thyroid function test, how the assay works, which are there in common clinical use, and which will help us understand further the clinical problems that we encounter and how various laboratory errors can make our judgment difficult for our patient and how we can overcome that. To begin with, this is the typical hypothalamo-pituitary thyroid axis, how it works. As all know, like any of the endocrine diseases, the interplay between different glands at different levels actually is responsible for various kinds of thyroid function tests that we tend to observe in our day-to-day clinical practice. So TRH is a hormone, as you know, which is secreted from the hypothalamus. It stimulates the anterior pituitary thyroid trophs, which produce TSH, and that in turn stimulates the production of T4 and T3 from the thyroid gland itself. This enters the circulation and it binds to the thyroid receptors in various organs of our body. There are various kinds of receptors. Alpha and beta are the most common ones, and the thyroid hormone enters the cell via different transporters and they act on the nucleus. Now, in this pathway, this axis, there can be many problems which you need to understand in the background of a particular thyroid function test that you get. Now, just to give an example how the laboratory methods of thyroid function test evolved over a period of time. Initially, we had a test called protein-bound iodine, even in the institutes. Now we have LCMSMS. Very few centers worldwide has this facility. But what we mostly do is chemi-immunorescent assay. So what report you see are mostly CIA, CLIA, or some variant of this. Some labs may report still in these parts, maybe with ELISA. In fact, in Calcutta, there are many labs still now we use ELISA method. So these are important things to remember when you see a report. Now, when we look at a report, there can be a source of error from many parts of a particular test. As you can see here, the pre-analytic phase, that is not the machine in which it is actually running, but prior to that, what has been done, starting from drawing a blood sample to the putting this sample in the machine. So there can be a lot of problems. So those are called pre-analytic errors, and those are very important not only for thyroid function but for other tests as well. But what we focus today is on the analysis part. Now regarding TSH, as you know, this is the most common test which we ask for when we talk about thyroid function, and it's a very reliable test for the diagnosis of abnormality of thyroid function. Okay, and depending on the lower limit of the TSH hormone, that is that we are able to detect, there are various generations of assays. Most of our labs now have third or fourth generation assays. I won't go into detail of those. Just this is mainly for postgraduates who are there. It will also help clinicians to understand how this assay works. When we talk about an assay regarding a hormone, we have analyte, that is the hormone in circulation, like T4 or TSH. We have some labeling, I discussed that later on. There are antibodies which can be used, which is labeled with a particular signal, or those can be fixed on a matrix, solid matrix, depending on the assay types. But various kinds of antibodies are used, like monoclonal, polyclonal, which are taken from a natural animal source. Monoclonal is mainly from a monoclonal cell line, and engineered polyclonal, where we mix a different kinds of monoclonal antibodies together to form a polyclonal-like antibody. Now, those are again very much those are nitty-gritties. If you are interested, we can discuss this later on. And there are some technical terms like liquid and solid phase. Again, I won't go into detail of this. Now, TSH is a hormone which is measured by an assay called immunometric assay. What is that? In simple terms, there is a solid phase. Imagine it as a plate on which you have fixed some antibodies. So these are called capture antibodies. Why? Because they capture the hormone. This black one here is the antigen, the TSH. It captures the TSH and fixes it with this plate.
This light is not moving.
Oh, it's not moving. Again, it's not moving. Okay, so that's the thing I was talking about. Sorry for the technical glitch. Now this is the antigen. Again, it's not showing here. Okay. Anyway, you can see the black things here. That's the TSH, and these are the capture antibodies that I was talking about. And you have another set of antibodies. It's not working. Anyway, you have another kind of antibody where you can see there is a green figure attached to it. These are called labeled antibody. So what happens? Basically, when the TSH is in the circulation, it is in the blood, and you have put the sample in the machine, it binds to the solid phase via this capture antibodies. And then after washing, these labeled antibodies are added. Now there is a formation of sandwich-like thing. The TSH is sandwiched between two different kinds of antibodies. Yes. Now what happens with that? You can well imagine the higher the concentration of TSH in the circulation, more the generation of the signal. So the dose response curve again is not moving. It's kind of proportional. That is, higher the concentration of the TSH, higher the generated signal. So it's proportional. Now for T4 or free T4, T3 or free T3, another kind of assay system is used. What is that? Basically, it is known as competitive immunoassay. Why it is called competitive? Because here a small number of antibodies, which are capture antibodies, are used. And for that, there is a competition between, say, T4 and these red ones, which are like T4, but those are labeled. So here you can imagine, the higher the number of the more the concentration of T4, less the amount of signal, the signal attached analogs, those will be there in the solid phase. So after washing, higher the concentration of T4, lower the signal generated. Therefore, the dose response curve is just opposite. Okay. Again, I won't go into detail of the free hormone kind of assay because of shortage of time. Let's move quickly to the cases. Now, I would expect interactions from, particularly from the postgraduates who are there, but also from the clinicians if you are interested. So this 59-year-old female, history of surgery for CA breast 6 years back, with an ER and PR positivity in the biopsy sample. She was referred for deranged thyroid function test to us. As you can see here, T4 is high, 15.3, 12 is the upper normal limit, and TSH is normal. So what are the possibilities? Anyone? Just quickly. Anyone? Yes, please. You? I thought you raised your hand. Okay. Okay. So here you can see there is an elevation of total T4. What does it mean? The patient is ER and PR positive, and patient is on tamoxifen. Tamoxifen is a group of drugs known as selective estrogen receptor modulator. So basically, it stimulates the production of thyroid hormone binding globulin from the liver, therefore leading to the elevation of total T4. Okay. So if you do a free T4, that's what within the normal range. So here, in situation like this, free T4 is more reliable. So there are many conditions where this thyroid hormone binding globulin can be elevated, like in pregnancy, as Dr. Shinatra has discussed, estrogen therapy or estrogen modulator therapy, and other conditions like hepatitis, mainly chronic hepatitis, and some other rare condition, including some congenital conditions. Whereas some situation where total T4 can be falsely low, like use of androgen, someone is using testosterone at a very high dose for bodybuilding, nephrotic syndrome, and some rare cases like acromegaly, severe illness, or again some congenital conditions. Yes, okay. So there are other causes of increase in total T4 as well. There is some congenital condition where there is increase in some binding proteins that can also lead to similar things. Our second case, a 29-year-old female in second trimester of pregnancy referred by gynecologist. So routine thyroid function test was done, which showed a low free T4 and normal TSH. She is clinically euthyroid. Now what to do with that? Anyone please? Particularly those who have listened to Dr. Shunetra's lecture. She just mentioned this in a bit different context. Residents, anyone please? Okay. So as you can see, the free T4 is low but TSH is normal, and this is in the second trimester. So this is a condition known as isolated maternal hypothyroxalemia of second trimester. So here what happens, due to some alteration of binding proteins in the pregnant state, particularly from the late second trimester onwards, the free T4 assay by which we commonly employ can show a lower level of free T4. So here you can do a total T4 and you can adjust evaluate as Dr. has discussed, or you can do other kinds of tests and follow up these patients. These are mostly harmless situations. You don't have to do anything, particularly if it is a late second trimester. On the contrary, if T4 is low in isolation in the first trimester, that can be potentially harmful. So during pregnancy, many kinds of changes can occur in thyroid function test. I won't go into details as Dr. Sunitra has discussed those. A third case, a 29-year-old female came with palpitation for uncertain duration, tachycardia, there was small goiter, TSH is 4.9, normal range is 0.5 to 5, and T4 is high. So total T4 is high. What next? Again, residents, anyone? High total T4, you have some suspicion that it may be wrong. What you will do next?
Trap.
Before trap, maybe? Okay. As I've said, always suspect that total T4 will be falsely high, so you have to do free T4 as well. So you ask for amenorrhea, do a pregnancy test if there is amenorrhea, ask whether she is using COCP, okay? Or she is hypothyroid. Believe me, some patients, after coming to you, they you see the report, they don't tell you anything, and then if asked specifically, they will take out a thyroxine tablet from their bag. So there are patients like this. So always ask regarding this and regarding compliance. So poor compliance with thyroid medicines can have this kind of report. And of course, repeat with 3T4. Now here, as you can see in this patient, none of this positive and 3T4 is also high. So here we come across some rare, relatively rare set of conditions. I won't go into detail of that. It depends on the clinical situation. If the patient is hypothyroid and on levothyroxine, then as I said, poor compliance will be responsible. If the patient is clinically thyrotoxic, then there are some problems like Graves' disease with some assay problem which can lead to falsely high or falsely normal TSH and some condition known as resistance to thyroid hormone. And if the patient is clinically euthyroid, then think about the congenital conditions what I was discussing, the problems with the binding proteins. Now, antibody-mediated interferences can be different kinds. It can be due to autoantibodies or can be due to other antibodies. Rheumatoid arthritis is a common condition, and rheumatoid factor in a high concentration can lead to falsely high TSH level according to some reports. So specifically, as you can see here, without interference, it should look like this. But with a steric hindrance, this kind of antibodies, then the TSH can be falsely low. With a formation of bridge between these two kinds of antibodies, without the analyte, the result can be falsely high. And with T4 also, there can be falsely low level. So there can be a lot of confusions if you have antibodies there. Again, due to shortage of time, I will go into detail of this. We saw in a set of patients with rheumatoid arthritis who were seropositive, we did not find any significant interference with the modern day assays because they already add these antibody blockers in the assay systems. In this particular patient, the TR beta mutation, thyroid receptor beta mutation, was the diagnosis. So I think due to this technical glitch, there was a lot of wastage of time. I will just go straight away to the take-home messages. So discrepancies between clinical and lab parameters are not very uncommon. Okay? You have to be aware of that. So always think of interferences. The problem with these assays can be in different levels, starting from the collection of sample to the transport to the lab and the assay itself, and then generation of result. The typographical errors can also occur. And different tests like, again it's not moving, okay. PEG precipitation, dilution. These are different methods that we employ in our laboratories to counter this assays. I will go into detail of this. So thank you all for being patient listeners. If you have any question, I would like to answer.
Thank you for your speech, sir. From the audience, if you have any queries, you can feel free to ask.
Thank you, sir, for that wonderful talk. For the benefit of the audience, sir, could you please tell us in short, do we do a T3 or a FT3 as has been done as part of many thyroid function test packages, or maybe many clinicians believe that doing a T4, T3 TSH is perhaps the right way of doing it. Could you in short tell them?
Right, thank you. So it depends on your clinical situation. See, if you ask for TSH, free T4 and free T3, most of the labs that will give you a value where you can find that free T3 range, free T3 value is in abnormal range, and you get confused. So it's better not to advise for free T3 at all. Even total T3 is for some specific purpose. Like when you are suspecting a patient is having thyrotoxicosis, then you can ask for T3, and in preference, total T3 should be advised, not free T3, because free T3 concentration in our circulation is very, very low. And therefore what happens, the assay which we employ, there can be many fallacies with these free T3 assays. So do not rely overtly on that. Always ask for TSH if you are strongly thinking about primary hypothyroidism. Follow it up with free T4 or free T4 if the TSH is high. Otherwise, if you are not that sure, you can ask for T4 and TSH to begin with. But all the three tests together is needed rarely, possibly only in the context of thyrotoxic state.
So one question.
Yes. Okay, yes.
On the sometimes patient come with T4, high T4 and FT4 level, and also TSH is also raised sometimes.
Right.
So how should we explain that, and should this kind of patient require treatment?
Exactly, a very good question. Again, that depends entirely on the clinical context. Say, if we are getting a patient who is clinically thyrotoxicosis, patient is having clinical thyrotoxicosis, okay? Patient has tachycardia, patient has sweating, anxiety, you feel that this patient is having thyrotoxicosis, and then you get this kind of reports. Always think about few things. Number one, it's a Graves' disease with antibody towards TSH, which is actually causing false elevation of TSH. So in Graves, you expect your TSH to be low. That's number one. Number two, the other two are rare conditions, but you can find those. What are those? You can have an adenoma in the pituitary gland, which is secreting excessive TSH, and that is stimulating the thyroid gland to produce T4. So TSH and T4 both can be high, or TSH can be apparently within the normal range, but T4 is high, which has similar connotation. And third condition where it can occur, I showed in that patient, the female patient, it's a congenital condition known as thyroid hormone resistance. So there the problem lies in the receptor level. Okay, so if there is a mutation of thyroid receptor type beta, that can also give rise to this kind of thyroid function test. But all the three sets of patients will be thyrotoxic. On the other hand, if the patient is say euthyroid and you are getting this kind of report, then always think whether this T4 is falsely high or not. Now, as you have said, the free T4 is also high. Now, again, it may look like a bit more complicated. There are some congenital conditions like some TBG excess, where both T4 as well as free T4 can also be high. But those are extremely rare. There, we ask the patient to do it from a lab where LCM SMS is done, but again, it's done in a very few labs. Okay? And secondly, the more common, much more common rather, the use of OCPs, which are often not disclosed. You have to ask for those.
Thank you, sir.
Thank you.
Thank you, Rana sir, for that talk as always. Rana sir is always invited to talk about laboratory errors in various hormonal tests. He was the in charge of the hormone laboratory at in Department of Endocrinology IPGMR, and we've learned a lot of laboratory medicine from sir. Request our chairpersons to felicitate Rana sir for this wonderful talk. Dr. Shubhendu Mishra, Dr. Gautam De, and Dr. Falguni Chakraborty. A big round of applause for Dr. Rana Bhattacharya and our chairpersons. I request Dr. Shubhankar Bhattacharya, Senior Obstetrician and Gynecologist, and Dr. Ashish Ghosh to please come on stage and felicitate our chairpersons for this session. Dr. Shubhankar Bhattacharya and Dr. Ashish Ghosh to felicitate our chairpersons. Dr. Falguni Chakraborty, Dr. Shubhendu Mishra, and Dr. Gautam De. Thank you, chairpersons. Thank you, everyone. We now quickly move on to our next session, which happens to be adult medicine primarily, about subclinical hypothyroidism. To chair this session, I request on stage Professor Sukomal Bishoi, MSB Medical College, Purulia. Sir has always been kind enough to give time for these kind of academic functions, and he is an academician. Dr. Tapos Chandra Das has been one of the most supporting seniors and teacher that I had while doing my DM at IPGMR. He is assistant professor at Department of Endocrinology, IPGMR Kolkata, and Professor Gaurango Shatra. Gaurangoda is currently head of the Department of Medicine at Devan Mahanta Government Medical College Hospital, Kolkata. Gaurangoda is also one of the most academically oriented persons that I have met recently, and we are doing academics together in Purulia. And I request our chairpersons to introduce our speaker for the next session, Dr. Anirban Mujumdar.
Dr. Anirban Mujumdar, well-known endocrinologist from Kolkata, will speak on subclinical hypothyroidism, which is going to treat. Subclinical hypothyroidism is a very common problem in community. Up to 10 to 15% cases are in community subclinical hypothyroid. But as it is mild disease, majority do not need treatment, but few need treatment. Dr. Anirban Mujumdar will speak regarding this.
All sessions were definitely very much interesting, but this session, I think it will be the most interesting of today's all of the sessions that yet already happened. And because we, the senior persons, senior clinicians, all are waiting, যে শেষটায় কি হলো, ট্রিটমেন্টটা কি হবে, ট্রিটমেন্টের কোনো পরিবর্তন হয়েছে কিনা, বাকি সব অনেক কিছু জানা হয়েছে। ওই সব হলো এতদিন ধরে ভোট হচ্ছে, ভোটের রেজাল্টটা কি, ওই রকম মনে হয়। এইটা সবাই ওয়েট করে থাকে এটার জন্য। সো
Thank you. Thank you very much for the introduction, and thank you to the organizer for inviting me and giving me this honor and privilege to be in front of you, and special thanks to Pankaj. So this is the talk is subclinical hypothyroidism, which I think all of us face. Lot of cases we face in our everyday life. So I will discuss some cases. I think that will give a better understanding that what we should do in a given situation. And these are the situations that we face commonly in our day-to-day clinical practice. But before I start, let me say that the subclinical hypothyroidism means that your thyroid or the T4 or free T4, whatever you say. As Rana has said that we should always check free T4 and TSH and don't cast T3. So we check conventionally, customarily FT4 and TSH, and if you find that the FT4 is normal, irrespective of the TSH value, it is subclinical hypothyroidism. And there are certain situations which actually looks like subclinical hypothyroidism, but these conditions I am not going to discuss. So I will consider that they are outside, and I will consider some clinical situation where these factors are not interplaying. So sixth question is why we should treat, because the T4 is normal, the active hormone is normal. So patient is also euthyroid, and if there is any symptom, these are all useless symptom which is present to almost everyone. So why I should treat? This is the first question. Now, if we look into the data, number one, we find that the patient with subclinical hypothyroidism may develop overt hypothyroidism over a period of time, and it depends on three important factors: that the age, higher the age, higher is the chance. Second is TSH value, higher the TSH value, higher is the chance. And third is the absence or presence of anti-TPO antibody. Higher if the anti-TPO antibody is positive, there is a higher chance. So my first case, that is a patient with young patient with TSH value more than 10. This 38-year-old woman, they gain some weight, and everybody gaining weight will tell you that I am gaining weight because of thyroid disease. Everybody has this issue. Now, it is very difficult to convince the woman to say that the thyroid is not responsible for your weight gain. Now, this patient, you can see the anti-TPO antibody is negative and TSH value is 12.2. Should we treat? This is a very common situation, very common question in front of us. Now, I think many of us will treat. Actually, if you ask me, I will treat this case because of the fact we have the guideline. This is the European Thyroid Association guideline, which suggests that anybody below the age of 65 or 70, if the TSH value is more than 10, we should treat. So this is number one. Having said that, I must tell you, this is a very not very old publication in BMJ and a clinical practice guideline, which suggests that if the TSH value is less than 20, there is no point of treating. So please remember that this is a guideline which suggests if the TSH value is less than 20, then there is no point. Guideline has said up to 20 of treating. So I leave it on your wisdom that whether you are going to treat this patient or not. Second is that the patients with TSH value less than 10. Now this particular patient, you can see same patient. I've just changed the two things. One, the TSH value less than 10 and anti-TPO antibody is positive. So again, the question is, should we treat? Now, if we look into the guideline suggests that any patient with subclinical hypothyroidism, we are supposed to test TPO antibody. You are getting a subclinical hypothyroidism,